Once again, good evening, all the doctors. Warm welcome to the series of Nova Journal Club. And today, of course, in the series of Nova Journal Club, we have another interesting topic to discuss in today's webinar. And as we all know that September is being observed as the PCOS month, and today's topic is in relation to this, challenges in controlled ovarian stimulation in PCOS patients. Before we get into an introduction of an experts, moderator, and the panelists, it gives an immense pleasure and the pride moment for us in introducing and also been congratulating both Dr. Rohit Gudkotia and Dr. Sonia Malik ma'am. And we warm welcome to you, sir. Dr. Rohit Gudkotia has been now the new medical director for the Nova IVF group. And again, Dr. Sonia Malik ma'am has been the chief clinical mentor for the Nova IVF group. And in the people who practice infertility, at least in the country and abroad, I think these are the two permanent faculties where doesn't require of an introduction. So very, very warm welcome to both of you, sir. And I think as always been the clinical excellence in the Nova IVF, with your leadership is also will continue to be there as a clinical excellence and setting a trends in terms of the IVF practice in the country, in the industry. Very warm welcome to you. And I request Dr. Sonia Malik ma'am to please introduce our expert and the moderators, ma'am.
Good afternoon to everyone. Good afternoon. And a very warm welcome to Dr. Raj Mathur. Thank you for being here with us. Let me just introduce all of you and start this. I'm sorry for being a little late. There was a technical glitch in my laptop. Well, introducing Dr. Raj Mathur, he's our expert today, and we are very, very proud to have him here. He's a consultant gynecologist, subspecialist, reproductive medicine and surgery at Manchester University Hospital, NHS Foundation Trust. What makes us really proud is that he's basically from our fraternity. He did his post-graduation and graduation here from India, from Pondicherry, and therefore, after that, he has gone and really shone in his tenure abroad. He has been the advisor to HIFA, and he is also a member of the NICE Fertility Guideline Committee. And we all know that he is extremely, extremely popular for his paper on OHSS and his guidelines on OHSS. So who would be better here to lead us than Dr. Raj Mathur? Our other expert is another great luminary from India, Dr. Bharati Dhorepatil. She's a fertility specialist working in Nova Fertility now at Pune, and we all know her as a very successful vice president of Foxy a couple of years ago. So Dr. Bharati Dhorepatil and Dr. Raj Mathur, welcome today to this webinar. And then let me also introduce my two colleagues. Can I have the next slide, please?
Yes, ma'am.
Isha, can I have? Yeah. Can I have? Yes, thank you.
Yes, ma'am. It is
Thank
done.
you. My moderators are no less. My moderators are no less. We have Dr. Lakshmi, and Dr. Lakshmi has been a very senior gynecologist and fertility specialist with us at Nova. She is leading the Banjara Hill and LB Nagar offices at Hyderabad, and she is extremely, extremely successful over there. We also have Sneha Sathe, again with Nova at Chambur, Mumbai. And we know that these two bright girls are really going to moderate this session and take it forward in a very successful manner. So I hand over the mic to them now to introduce their panel and take you through this webinar. Thank you very much, all of you, for being here with us today. And over to Lakshmi and Sneha.
Thank you, Sonia ma'am, for such a warm introduction. A bright and warm welcome to our experts, to Sonia ma'am, to Dr. Rohit, and to our esteemed panelists. It's a great pleasure and privilege to introduce our panelists. These are all senior fertility specialists from the Nova centers all over India. Dr. Krithika Devi, she is at Nova IVF in Chennai. Dr. Mahesh at Nova IVF in Bangalore. Dr. Mona at Nova at Surat, and Dr. Sandeep, of course, at Vasant Vihar, Delhi. So without further ado, I would go ahead and share my presentation, and let's begin today's discussion. So we are all gathered here today to discuss challenges in controlled ovarian stimulation in PCOS. This is because September is PCOS Awareness Month. Now, PCOS is a condition that often sparks differing opinions among experts. I think it's a condition where we all agree to disagree. The diagnostic criteria for PCOS have been subject to continuous modifications, and also the guidelines for managing PCOS have remained in a state of flux. So why do we need an entire month dedicated to PCOS awareness? That's because PCOS is the most common endocrinopathy affecting women of reproductive age. It is a complex condition with reproductive, metabolic, and psychological features, and it's a heterogeneous disorder with varying presentation of hypoandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. I think everybody will agree that we don't find two women with PCOS who are exactly the same. So the diagnostic criteria for PCOS basically have been changing over the years, and these three criteria have been there till date. Of these, the ESHRE, ASRM, Rotterdam criteria are the ones that are majorly followed. Now we'll come back to the Rotterdam criteria in a couple of slides later. The Rotterdam criteria were modified in 2012, and this new classification defines 4 different phenotypes in the expression of PCOS. In 2018, the International Evidence-Based Guideline for the Assessment of PCOS was developed, and this was presented at the ESHRE Annual Conference in 2018. This guideline was updated in 2023, and the idea was to provide clear information to assist shared decision-making and support optimal patient care and better health outcomes. So this slide, only the initial few terminologies are important to understand. Later on in the slides, you will find reference to EBR, CR, and PP. EBR refers to evidence-based recommendations where the guideline development groups found evidence sufficient to make a recommendation. CR refers to consensus recommendation, and this was in the absence of adequate evidence. And practice points refers basically to practice points where evidence was not sought, but a practice point was made. So first, let us discuss the ASRM, ESHRE, Rotterdam criteria. So can I have someone from the panel who will just elaborate these criteria or just enumerate the criteria with more emphasis on the PCOM morphology? Did the 2023 guideline tell us anything specific, particularly on PCO morphology?
2003 guidelines are quite followed from long time. I think one of the long-standing guidelines are this, and actually there are two of the three criterias were allowed or defined. That is either a clinical or biochemical markers of hyperandrogenism, or anovulation or oligo-ovulation, or PCO morphology. These two criteria, if it fills, then it was 2003 ESHRE Rotterdam criteria, which is now even still followed in most part of the world. And then yes, there are different criteria, but I think this is the long step.
I think we'll all agree that as far as fertility specialists are concerned, the PCO morphology part is very important to us because it helps us decide the type of fertility treatment that we are going to offer. And did the 2023 guideline have any specific recommendations regarding PCO morphology? Regarding the number of follicles that we need to see? Dr. Krithika, would you like to go for that?
Earlier, the numbers they gave is now different from what 2023 guidelines are saying. Earlier, we used to think if there are more than 10 antral follicles in each ovary, that is a PCO morphology, and the size has to be between 2 and 9 mm. But now, they've made more stricter criteria. They say almost 20 antral follicles should be seen in each ovary, or in just one section, at least 10 antral follicles should be there. So there is a change in the number of antral follicles. And the next important thing is not just the antral follicle, the volume of the ovary also has been given importance. They say the volume should be at least more than 10 mm.
I think one practice point here is for us that many times we have patients walking into the OPD and they come with an ultrasound report and say, doctor, I have PCOD, just because the ultrasound report mentions polycystic appearing ovaries. But if you take the clinical history, the patient doesn't have irregular periods, she doesn't have any signs of hyperandrogenism. So we have to do a lot of counseling for such patients that, you don't have PCOS. I think it's important for us to raise awareness even among radiologists regarding the PCO morphology criteria. Anything about AMH, doctors? The new guideline also includes AMH as an option for determining PCO morphology.
So AMH should not be used as a single test.
and it is used in adults but not in adolescents. So that is one thing which is very important. And when we are using AMH, you can either do an ultrasound and say PCOS, or you can use AMH. So both together are not really required to define PCOS.
I think in our practice also it's a little difficult because, you know, we have different laboratories and the AMH values don't really go well in all the labs. So sticking rather to AFC on ultrasound will help us guide treatment basically.
Most effective is what we see is what we believe. We have everybody has the ultrasound machine with them. Just see the number of follicles. I think follicle number per ovary is something that will be more reassuring.
It even guides us for stimulation later on, whatever.
Right. Dr. Lakshmi, over to you.
Yeah. Before I go actually into the topic, I just want our experts to comment on this AMH and PCOS. Dr. Mathur, please. What is your practice in UK? How do you deal with this?
So in the UK also, we still use the ultrasound criteria to diagnose the PCO morphology, and we still use clinical features to diagnose the polycystic ovary syndrome. I think AMH is particularly used by fertility practitioners to guide the initial dose of stimulation and to counsel the patient about their risk of hyperstimulation. And I think it's a viable strategy to use an AMH cutoff to decide on elective freeze of all embryos. So in our practice, we tend to use an AMH cutoff of around 35 picomole per liter to freeze all embryos electively, even if the response isn't particularly high. So yes, so for diagnosis, we tend to use ultrasound scan, and for planning fertility treatment and advising freeze-all, we have a tendency to use AMH. Although I think you could also use antral follicle count for that.
That's a very good point for all our audience, Dr. Mathur. So at primary and secondary care levels, definitely we don't need an AMH to identify the PCOS syndrome, but at the infertility level, at a tertiary level, we might use AMH along with the ultrasound to identify the patients at risk of hyperstimulation. Thank you so much. So next, coming to the actual management of subfertility, I would put this question to any of our panelists. What is the first line of treatment you would use if the patient comes to you for the first time? She did not undergo any treatment before.
Definitely weight loss is something that is more encouraging and more desirable. But then feasibility and practicality, we have to see whether patient has already tried, because we have to consider the age, AMH and other factors in relation to weight loss process, because it's not going to happen overnight.
Exactly.
So if the young patient and still there is time, definitely yes, that is number one. But then if they already struggled with it and we cannot wait for a long time, we'll have to go for the next procedures with ovulation injection.
Exactly. Anyone differs from this?
Yes, so I agree with that it should go hand in hand. So simultaneously, the weight loss of at least 5 to 10% would be a very good help to us in. So I usually tell my patients that this is what you have to give me. And then along with that, I would give you, medications and things to.
I would like to ask Dr. Raj, how is the UK practices? I think they wait for a long time for them to lose the weight.
So it becomes quite difficult we ask them to lose weight, we motivate them. And I like what Dr. Mona Shroff said about, I call it negotiating with the patient. You give me a bit and I'll give you a bit and we will work together. It shows you're on their side. So what I do is I give them, you have patients with BMI of 40 plus. So I give them targets and say, okay, you reach 35 and I'm happy to give you letrozole. You reach, so that kind of individualized discussion, and bring metformin into it as well. The point I wanted to make was that we say lose weight and we say come back. And sometimes what happens is patients don't lose weight, and then just like about a month or two before their IVF, they go on a crash diet. And I think that might not be good for their success rate. So I always say to them, lose weight before treatment. But once your treatment starts, don't lose any more weight, because evolutionarily, we are not designed to lose weight in pregnancy. And actually, acute weight loss during stimulation may be bad for your outcome. So I'm not sure if that is completely evidence-based, but it makes sense to me.
Yeah, they say that you should have a stable weight, Dr. Raj Mathur, when you're starting. Yes.
Dr. Krithika, you want to add something?
Yeah. So the common question that the patients ask us once we say lose your weight is, should I join a gym? That's the first thing that every patient asks. So I think we should always recommend them an exercise that they can sustain, as Dr. Raj Mathur said, during pregnancy also, during stimulation also. So I generally recommend at least go for a simple walk every day. A moderate speed walk of half an hour every day should be sufficient. And number two, the next question they ask is, should I wait for me to lose 10 kgs and then start treatment? So here again, our counseling should be, both should be hand in hand. There is no full stop to you lose weight, then we start treatment. I feel treatment should be combined with exercise and it should be continued even during pregnancy. So I think that is a factor. And what type of exercise, when they ask, then again, it's not just going to gym, just losing your sedentary lifestyle, climbing stairs, getting up and taking your things. So even daily moving around should be a practical tips to them. So they need not exactly go to gym and exercise and lose weight and start treatment. So that is something we have to tell them.
True, because many times they tell us that, we don't have time or so. So indirect exercises. So I ask them to use the stairs instead of the lift and those stuff. And then there is this kind of QR codes which we can share. So the patient just has to scan and they'll get all the exercises and yoga and diet tips as a YouTube videos there. So that becomes easier for them.
That's great inputs. Can we move on from this? I have got 3 scenarios here. A patient 28 years, not started planning yet. BMI 25. She has irregular cycles. And 31-year-old with a BMI of 29 and has been trying for the past 2 years. And 37-year-old with BMI of 35 years. So would you defer your counseling in any of these patients, and how do you do it?
First patient is definitely, she's young and she has been just recently married and quite a good BMI, and I think she can still wait. Just we will have to do the basic ultrasound to see the ovarian morphology and semen analysis and tubes, and this everything is fine. Yes, she can wait, and that's not a big thing.
Yeah, the second patient, Dr. Krithika, what do you do?
Yeah, for the second patient, first recommendation, since a BMI is on the higher side, first thing would be diet and exercise. That will be number one. And number two, we have to rule out other causes of infertility before we begin. For example, the male partner has to be evaluated for a semen analysis. That is usually forgotten and taken care only at the end. And we have to do an evaluation of tubes also. So if everything is okay, then we can go for a simple ovulation induction and natural trial. The sperm count is normal. And then move forward. If it is not working, then go on to IUI later.
Okay. Dr. Mona, the third case, like to take it?
Yes, so I think that she's an elderly, advanced age, trying since a long time and with a very high BMI, 4 IUI failures. So she's definitely a candidate for IVF without delay. But at the same time, the higher BMI also, if like what we already discussed, if possible, we can try managing that along with her IVF. But otherwise she is directly, and then we may even have to give her the alternative of PGT or other options because of her age.
Would you start immediately or would you wait for the weight loss?
So as I think already discussed, a crash weight loss is not advisable, but at the same time it may not be possible also. So waiting for say 6 months or 1 year would not be advisable at 37. So probably I can freeze the embryos and then suggest her for some weight loss and then maybe transfer those embryos.
Yeah, I have our experts, Dr. Bharati and Dr. Raj, to comment on this. Would you wait or would you start? What are your options for this patient? 37 years, BMI 35, failed cycles.
Am I audible?
Yes.
Yes.
Give me a scenario 28 years, 31 years, and 37 years. The best patient would be for me 31 years. Catch them young. I would not wait for her for a long time with, say, timely intercourse and IUIs. Maybe IUI 1, that's it. So that's the best way to see. Catch them young is very, very important. I would like to see the patients whether it is a resistant PCO. See, only PCO thing to the patient. If it is a resistant PCO, she's not been able to get ovulation at all. These patients not likely to wait for simply timely intercourse and IUI. This is not my opinion. We have actually audited our patients, and this is the way I think the new way of management of PCOS. 37, as Mona said, this is very right. I don't think we should be waiting at all for this patient. Not even for optimizing her BMI also, just straight go for IVF. Maybe once the embryos are there, you can make her wait for a while and then go ahead. I would like to know basically AMH level of every patient whom I'm treating as a fertility specialist. That is must for me. Antral follicle count and AMH go complementary to each other. It's not only one, but that definitely makes us understand the line of management. So I think the panelists are correct. The first patient is definitely we can be little lenient.
So definitely age is an important factor while making the decision in fertility treatment. And a 37-year-old, even though the BMI is high, it's optimal to go ahead with the treatment rather than wait for her to lose weight. So any patient, first thing is optimizing the preconception health, that is BP, weight.
Just 1 minute. 37 years, when the BMI goes 35 and above, they are morbidly obese.
Yes.
See, they are morbidly obese. You don't talk about their weight loss. It is very difficult. It cannot be done. It is very difficult in the sense for your stimulation also, even for your ovum pickup also. 35 BMI is a very big BMI. It is very difficult at that time. If at all patient is very, very keen on reducing, I think obesity surgery is the only option for that patient. 35 BMI is a morbidly obese patient. So
yeah.
But bariatric surgery, Dr. Bharati, bariatric surgery is being advised for this kind of a patient. Bariatric surgery.
We'll come to bariatric surgery, ma'am. 2 minutes.
They will come to bariatric.
So any specific diet, we have already discussed about the exercise. Any specific diet that you would advise? Next slide.
I think a low glycemic
index. You should have you should have a food which is high in proteins and low in your carbohydrates. So that is a kind of calorie, it should not be calorie dense food as you classify the food according to the calorie. So the calorie dense food should be avoided in those patients.
Yeah, definitely. Even the guidelines say the same thing. Weight loss of 5% is necessary. Patients who are overweight, their response is less to the fertility treatment. Their time to conception is more, and they also have high risk of miscarriages because of their weight itself. So a 5% weight loss is what we need to be looking at to improve their metabolic status and also the reproductive status. We all know about it. But what the guidelines says is, there is no evidence to support any type of diet over any another. Promote sustainable, healthy eating tailored to individual preferences and goals, and avoid unduly restrictive and nutritionally unbalanced diets. So we shouldn't be following anything in a strict way, but we should reduce our calorie intake. Next slide, please. Lack of evidence to support any one type and intensity of exercise over another. But what they recommend is at least 30 minutes daily exercise, and self-monitoring and self-motivation is important. So we have to motivate our patients so that they can follow this. Next slide, please. So coming to bariatric surgery, Dr. Sandeep, you want to put some light on this?
No, I'm just saying the people, the people who are morbidly obese, where you know that when you are giving any kind of diet or exercise, it's not going to help them. And as we saw the evidence, if the patient is over a certain amount of BMI, then even your ovulation induction becomes difficult and you don't respond that well to ovarian stimulation. So in those patients, it is indicated. But having said that, only once the patient achieves a certain weight loss or a weight which is stable, only then will you start. So this is the...
What are the advantages that we will get by losing weight? Dr. Krithika or Dr. Mona?
Yeah, even a 5% decrease in the weight will improve the response to stimulation.
Bariatric surgery,
So-
what are the things you will counsel the patient for while you are advising? Dr. Mahesh, you want to take?
Yeah, it will reduce the first thing is menstrual irregularity will be there. So that regularization will happen, and it will help in improving the parameters of diabetes if they are diabetic, type of diabetes, and it will help them, sometimes immediately they will conceive. So because of that, sometimes we need to ask them to wait certain duration, and the risk of preeclampsia or the hypertension related complications or GDM will reduce, and large for gestational of the babies and hirsutism, all these things, it will benefit to greater extent.
Next slide. So what do you suggest, Dr. Mathur? What is your practice in UK? Because it is NHS led, and do you have access to bariatric surgery for these type of patients who come for fertility?
So it is a challenge because it is delivered by a different part of the NHS to the fertility sector, but we are able to refer them for a discussion of bariatric surgery if they have a BMI over 40, particularly if they have comorbidities such as diabetes, then they will be considered. They have to first lose some weight. The NHS will only do bariatric surgery if you have shown your own willingness. And there is a program here which is run, it's called More Life. So they get holistic care, and it's not they can walk in and get bariatric surgery. It's an integrated care system. So they have to first show willing to comply, to adhere, and then they can access bariatric surgery. So it's really, we advise it for people with a BMI over 40 and with comorbidities. Your 37-year-old, Dr. Bharati raised a very important point about her AMH, because her BMI is 35. In practice in Manchester, we would not be referring her to bariatric surgery, partly because she's already 37. She has bariatric, then she has to wait about a year before she can. So, already time is ticking on. And I think there will be a drop in her success rate between 37 and 38, because at that time, even a year makes a difference. So I wouldn't refer her for bariatric surgery in our setting. But if you have easier access, maybe you would. Yeah.
So what is your experience post bariatric surgery? Did you treat any of your patients, and what was the response like?
Most of them have conceived on their own. It's remarkable the difference it can make. So we have had a few who've had bariatric surgery in the past, and then their responses good, but we are talking more than 2 years after the surgery when their weight is very stable.
Right. So would you recommend any fertility treatment post 2 years of bariatric surgery? Is that right?
I think rather than saying an arbitrary time limit, the weight should be stable. And there shouldn't be any micronutrient deficiencies. So we get a dietitian opinion. Yeah.
Did you notice any effect on the ovarian reserve of the patient post bariatric surgery?
Nothing that I can link to the bariatric surgery, but yes, if you take 2 to 3 years, then it'll have gone down, and that's not the result of the surgery.
Okay. So the guidelines also advises the same thing. Bariatric surgery can be considered in patients who are morbidly obese or who have any other comorbid conditions like hypertension, diabetes, and irregular cycles, especially in PCOS patients. And we should counsel the patient because, they might be ready to conceive. They might be their fertility might be increased immediately after bariatric surgery. So contraception should be advised, because immediately after that, they might be at risk of other micronutrient deficiency, and the pregnancy might be at risk. Next slide.
Don't allow only for anybody to become pregnant after. We have a series of obese patients. My husband being the pioneer in obesity surgery, bariatric surgery. We have a lot of patients undergone bariatric surgery before, and we've seen after they become pregnant and when they come for infertility. Number one observation is after bariatric surgery, they need to wait for a year's time, as you said correctly, because the stomach size, which has been very small, it will be all of no use. So they have to wait for 1 year. So what we actually started recommending to over a period of time to the patients that go through the cycle, IVF cycle, freeze those embryos, and then go for bariatric surgery, and then go for the embryo transfer. In that period of time, she does excellent during the pregnancy, because everything is optimized completely, and then but natural conception with morbid obesity, as Dr. Raj said, here we take 35, 40 with comorbidity, very, very unlikely that they get pregnant on their own. Very, very, very less percentage of the patients. We have hardly seen, we have completed, I think, 100 patients, and I have not seen a patient who has been, their profile also doesn't change, like follicle size and the number and everything, which we think that it will all change. It doesn't change that much. It doesn't. But their comorbid conditions definitely improves in that. But fertility still remains a challenge to them, this all women. So this is what our own experience with especially morbid obese patients, PCOS patients.
That's really interesting to know, ma'am. So the final take-home message is that bariatric surgery can be recommended, but again, we have to take age into consideration and the ovarian reserve of the patient, and also the comorbid conditions that the patient has. Sneha.
So basically, healthy lifestyle changes, diet, weight loss, exercise, this is advice that we need to give across all PCOS patients. In fact, any couple coming to us trying to conceive, adopting a healthy lifestyle is the main advice or core advice. So that brings us to ovulation induction now. This is a young patient trying to conceive since 2 years. Cycles are sometimes irregular. BMI is 26, AMH is 7. There is no male factor as such. And she has not had any fertility treatment so far. So she is a first timer to you. So how would you plan ovulation induction for her? You have done her fertility evaluation. You have given lifestyle advice. Dr. Mona, would you like to take this?
So I think I would prefer, because her AMH is also 7. So first line in my practice would be a letrozole. And those I would decide depending on the BMI. So sometimes we start with 2.5, and as per the response we increase, and sometimes we usually start with 5 milligrams per day, and then depending on the response we change. So that would be the first line. And as per response, if she is responding well, I may advise her to continue with the same for some certain period of time. If she is insulin resistant, then I would like to add metformin, and of course a folic acid and B12.
Okay. So now we are in the scenario that you have tried a couple of cycles of ovulation induction with letrozole, but she has not responded. So what do you do next? Would you try extended regimens? Dr. Krithika, would you like to take that?
Yeah. So my next step will depend upon her previous response, her BMI, and her age. So if letrozole has not worked with 5 mg for 5 days, I usually go for gondotropins. I have tried extended protocol with letrozole also, 2.5 mg for first 10 days, but my experience, I didn't get good outcome. So usually when letrozole is not worked, I tend to add a low dose of gondotropins.
Would anybody consider trying clomiphene?
No, I would like to do it rather than saying, I would like to do an OGTT and see what is her thing like. And if I feel that the glucose, the OGTT is deranged, then you will add an insulin sensitizer. I would as far as clomiphene citrate goes, letrozole is the first line drug. So letrozole has got much better results than clomiphene citrate. And if clomiphene citrate ever has to be used, it has to be used
along with
best
metformin.
effects are with metformin.
Right.
And she has occasionally irregular cycles. So probably if she doesn't respond to letrozole and it looks like a milder case, we may consider CC with gonadotropin.
Right, right. So now there is a patient who has been treated by another gynac. She has done multiple cycles of ovulation induction and she's now visiting you. She's just changed her doctor because she's not conceived. Obviously, she probably doesn't want to move on to, IUI or IVF. How would you? Yes, Bharati. Yes, sure.
Is it not the time has come that we should predict the response much before than what, trying for letrozole or whatever, CC or metformin and these all. I think there has to be set criteria, especially PCOS patients, which patients will respond to letrozole, which patient will respond to clomiphene citrate, which will be benefited with adding metformin. I think the time has come that do you all panelists think that the patient has got time to have 1 cycle and a 2 cycle and a 3 cycle and a 6 cycles, multiple cycles coming to you? All our IVF specialists over here, we all see that patient 8, 10 years has been trying the same thing again and again over a period of time. I think the time has come that we must know which patient has been responding to letrozole and which patient doesn't respond to the letrozole. So we will start actually looking at the patient very thoroughly, and we should see whether the patient is a hypoestrogenic or a hyperestrogenic patient. When the patient is a hypoestrogenic, it will never ever will add useful adding the letrozole, whether 2.5 milligram or 5 milligram. So the prediction has to be much before when you start actually looking at a sonography. Look at her follicles, look at her stroma, the follicle size, whether it is 2 to 4 millimeter size or a 6 to 8 millimeter size, it is a thin stroma, whether it is a thick stroma. This is all actually not seen by a routine gynecologist. And because of that, the letrozole, which is being now in the hand, is used, abused, overused, whatever it is. And then you just simply start looking at them as a failure to letrozole. So we have not started. Clomiphene has still place when the patient has actually hyperestrogenic. This patient will require a very good response to clomiphene citrate also. And you must know which patients can go for the gonadotropins. Like gonadotropins could be the first line treatment also for
some. Right.
Yeah, some patients. I think the time has come. We have been repeatedly saying the same thing again. First line this, second line this, third line this. And because of that, all acne patient when comes to you is almost lost very precious 5 to 6 years of their, good years. So I think as a IVF specialist, we all has to now look into the patients comprehensively and start the treatment. Why not to start a letrozole with gonadotropins to these patients? Why are you waiting?
So basically, we need to decide, we need to evaluate the patient and individualize the protocol, or not necessarily go in a stepwise manner as it is advised. Each patient is different, so we need not go as first line letrozole, second line gonadotropins. You could decide to take gonadotropins first.
You as an IVF consultant, a patient comes to you as an IVF consultant. Will you do only letrozole 2.5 milligram or 5 milligram?
Right, ma'am.
Then
right, ma'am. Dr. Mathur, you wanted to add something?
I wanted to agree with Dr. Bharati about the importance of time, because even we find in our practice, patients have been on ovulation induction of various types for very, very long period of time. And all that is happening is she's getting older. That's the only thing that's happening. I think a very important distinction is when we talk about failure of letrozole or failure of clomiphene is what type of failure. If she didn't ovulate, that's a very different situation to she ovulated.
Didn't get pregnant.
And we clearly need to separate the two. In my personal, I think letrozole is a good initial treatment for most patients, not the ones who are older, but for many patients, it's a good initial treatment. And to reduce the side effects, we don't add in metformin at the beginning, but we are happy to add in If we think that she will benefit, if she's not ovulating with letrozole, we're happy to add in metformin after 3 cycles to improve the chances of that. I don't think going from letrozole to clomiphene will make much difference unless you have a way of predicting, like Dr. Bharati was saying, and I think the prediction is not straightforward.
Right. So though there aren't many studies which compare letrozole and metformin to the other oral ovulogens, there is a role to add metformin in a certain group of patients. So the guidelines basically regarding metformin, they say that you can consider metformin alone for a woman whose BMI is above 25. You could consider for someone whose BMI is low but acknowledging limited evidence. And when giving metformin, we have to discuss this with the patient in concern. We have to counsel them about the adverse effects, and it's always better to start with a lower dose and gradually increase the dose. As far as ovulation induction is concerned, yes, the guideline does say that letrozole should be first line. If you're using metformin, it's better to give it along with clomiphene. Clomiphene and metformin are better rather than clomiphene alone or rather than metformin alone. But the guideline says that letrozole is the first choice drug. Anybody prefers to use or does use inositol in their practice?
Yes, we use inositols, and if you look at the guidelines, I know say that it should be used very guardedly, but if you read a paper which has come in 2023 about the use of inositols in PCOS, then this was a very large meta-analysis which was done. I think some 12, 13 things were combined, and it's a huge meta-analysis, and they see that all the biochemical parameters, including your insulin resistance, the OGTT getting corrected, your glucose getting corrected, your androgens coming low, your testosterone's coming low. And so I would say that there is definitely a place, although the guidelines don't say, but that if you look at the 2023 paper, January paper, definitely all the biochemical parameters are coming or getting corrected, but I would like to ask my experts what are their views about the paper, or Dr. Raj Mathur or Dr. Bharati, have they looked at it, and what is their take on the matter?
I can only say to my practice, I'm aware that there is evidence that inositol makes all those metabolic differences. In my practice, I use inositol, advise inositol where they're intolerant to metformin. And many of them are intolerant to metformin. So part of the problem for us is that inositol is not sold as a drug in the UK. It is sold as a food supplement, whereas metformin, you need to get a prescription. So a number of these patients, I'm sure without telling me, are already taking inositol. Yeah.
We use in our practice also few patients. We subtype the PCO patient and the patient who is being not tolerating the clomiphene, this metformin, definitely we do. We cannot document for sure whether it is, it's like, conclusively that it is helping, but overall, I think it is helping.
Dr. Lakshmi, over to you.
So we're coming back to this 35-year-old man. Her BMI is 35 and she has irregular cycles trying for the past 12 years, and there was no response to multiple ovulation induction cycles. What would you do next?
I think at the age of 35, she is a direct case for IVF with gonadotropins.
Yeah.
If she is not willing, IUI with gonadotropins can be tried, but then IVF would be more suitable.
But provided if her ovarian reserve is good,
yes.
Anyone take it in a different way? Would you go any slow, or everyone agrees that you will take her?
I think the only possible reason would be if she is not willing for IVF.
Yes.
And the history of OA, multiple cycles, no response, does it include gonadotropins or only oral?
Only oral ovulagens.
But 12 years is a very long time.
Very long time, yes.
And the tubal evaluation as well. So,
but the 35-year-old married, I would not wait. I would give IVF.
It's for IVF direct.
It's a practical case, not built up. So next slide, please. Next slide. So we do use gonadotropins, but what is the protocol in some of our patients who are not responsive to oral ovulations? And which protocol would you go for? What is the gonadotropin? Is there any preference? And the dose you will start with? And what are the various factors that you will take into consideration when you are deciding the dose? These are the three things.
Yeah, there are two types of protocol, basically, either a step-up or step-down protocol. Main features you need to consider are the age, the BMI of the patient, and previous, if there are any records of if they already underwent some kind of a stimulation with some dose, we can see. If the patient is thin, lean, or less weight, then you have to go for a step-up approach. If the patient is little obese or already not responded, then maybe step-down approach. So there are two types of gonadotropin approach we can.
So Dr. Mona, you've been quiet. How would you take it?
So for an IUI cycle, I usually start with the fixed dose only, because as per the BMI, we can take the call, and I prefer to use a recombinant in PCOS cases, because the biosimilar, like people who have been using HMG also, they say that HMG also gives similar response. But my personal experience with Indian HMGs has not been very. All the literature what says is compared with Menopure and the other form of gonadotropins. So I prefer to combine a letrozole with a gonadotropin, that is a recombinant, even for IUI cycles. And usually we give, why the combination is, it just acts as a complementary and reduces the cost of gonadotropins. And that is about the routine stimulation or IUI.
So what do you say, Dr. Krithika?
Yeah. And although technically they say HMG and FSH gives you an equivalent pregnancy and live birth rate, in practicality, I would prefer a recombinant FSH. The main advantage is dose flexibility. When it comes in a pen, I have a flexibility in increasing the dose. I can start with 50. If they're not responding, I can go to 100 instead of jumping to 75, 150 or 225, the options that are available with HMG. So 75 may be too less for her and 150 may be too high for her threshold. So the main advantage with a recombinant pen type would be the dose flexibility. So I would prefer to use a pen type of FSH.
A 35-year-old girl, you will start with 75 units? This is a 35-year-old woman, they are saying. She's married for 12 years. And
not just the age.
Initial starting dose will be 100.
It is not based on the age alone, is my opinion. Depends on her BMI.
So I'm just asking how many people will give for 35-year-old woman a dose of 100 units. I just wanted to ask. I don't use 100 units for a 35-year-old woman, even if she's PCOS. I won't start with less than. In my practice, in my 30 years of experience, I haven't seen anybody respond at 35 to less than 225 units.
No, ma'am, we are not talking about IVF. So
this is for IUI stimulation.
For IUI stimulation.
For IUI,
for
fine.
IVF, I've never started with 75 or 100. No.
Yes.
It's
I just thought in this case, if you got response, it's very good.
First of all, 35 years age patient, no IUI.
No IUI.
Okay, next slide.
I would definitely I will discourage her to my core. 35 years age patient, don't think that AMH means PCO means she has a lot of follicles, age is age, biological clock ticks. Even that whatever the follicles you see, they are all atretic follicle over a period of time. The 35 years of age patient, I will discourage to my core. That I will beg, I will tell her again and again that IUI is not the option. And that too, step-up protocol. No, it is very difficult. This 35 years patient probably will not respond even with your recombinant FSH only. She would require LH. So probably she will require FSH-LH combination. You can give. I have no objection for that. You can have recombinant FSH, recombinant LH, but she will require LH. 35 years of age patient has already lost. How many years she has? remaining now. So
That I agree with you completely, but the point to take here is the patient never ovulated. So let us give the
Benefit of doubt.
chance to try
the
natural.
moment it ovulates, we want her to take that egg out and best utilize it. So as an IVF consultant, at least now we know
I
that.
agree with Dr. Bharati and Dr. Lakshmi. Can you just go through the
IVF to all our patients. I think we have to give them the option of trying naturally because she never ovulated, though she's 35. So let us go on to the case. Day 3, AFC 12 and 12, more than 12. This was long back. So I started her on CC 100 milligrams with HMG 150. Gave only 3 doses because I was very bold giving 150 at this stage. On the day 7, there was no follicle growth. Day 10, again with 7 doses of 150, there was no follicle growth. And then on day 12, I have increased the dose. Any comments on this? This is a low dose step up regime, which I am following. And I have given HMG 225 and 150 alternate doses because in HMG, we don't have the via media dose of
37.
Is precisely that is the advantage with the parent IVF.
I have alternated with 225 and 150. Next slide, please. And on day 16, I could get 14.5. How many of you would say that you will give so many doses for an IUI? Would you agree or disagree?
Patients will disagree.
Yeah, it's expensive because it is expensive,
Absolutely right.
and so we have to counsel them about the cost related because it's an expensive treatment. Patient may object, so initially, before we begin, also we need to counsel them.
Definitely, we should counsel, especially when you are starting gonadotropins.
When you are we have given HCG 5,000 units and decapeptyl, do you think that all other follicles which are remaining behind, like 12, 13, 14, 15, not secreting estradiol at all?
No, there are no bigger follicles.
You said only 5,000 units with HCG with decapeptyl. I don't know.
You wouldn't.
I have not.
A practical case, we have done IUI because of her age 35, not leaving her naturally, and she conceived luckily. I want our expert. I know Dr. Bharati is completely disagreeing to my management. I take it. Take your
Sometimes, Lakshmi, Lakshmi, sometimes you are right because sometimes some patients are very, very adamant. They don't want to go for IVF at all. I told you I will counsel her to my core, but if she's not ready at all, rather than going somewhere else, the way you have been done with patient, very patiently, and you've been actually following her for this. But I don't know whether it can be generalized. That's what I wanted to know.
My only consideration is patient should ovulate and try naturally. Now, I would like to ask anyone who will agree with me or who disagrees with me, one comment.
Can I come in on one thing? I think you called this a low-dose step-up regime. Actually, if you go back to the low-dose step-up regime, this is not.
It is not.
This is a 2023 version where life has become faster. So the low-dose step-up regime has become a faster, accelerated low-dose step-up regime. In the low-dose step-up regime, it can take 6 weeks.
Yeah.
To occur, and the results are absolutely fine. But yes, I mean, what you did was valid. I can also see a reason for the decapeptyl. I don't think it's essential. I don't think this is wrong management. I think this is okay.
Yeah, this is not wrong. We are not saying it is wrong. But can you imagine her HMG dose was 150, 225 to begin with. Do you think that her ovary, when the antral follicles are 12 on 12, will only listen to only one egg? It's very unlikely, very difficult for generalizing the patient. Like this patient is lucky, anecdotal, it is very good. But generally, 12 egg.
Maybe what I will think, my consideration about this case is her age is 35 and BMI is 35. That's why she did not hyper-respond with this high dose. And I have continued the dose for a longer duration. I didn't increase suddenly also, maybe.
Yeah, but, and maybe your sonography picture, PCOM, that is morphology, if it is a hyper androgenic patient, which having a follicles 4 to 5 millimeter only, these patients definitely will have a high threshold and slowly you go up and one follicle comes up. It can possible. It is possible.
I think I'll go to next
Yeah.
discussion.
So risks and counseling are very important when we are taking up our patients. So especially regarding the expenses, because it is very expensive, and the success rate in gonadotropin stimulated cycles is not as good as IVF cycles. So it's only 10%, and they are spending so much on the drugs. So that needs to be taken care and informed to the patient before we take up the patient on, and close monitoring, and we should be strong enough in identifying the hyperstimulation risk and canceling the cycles. And here, the most important thing is not hyperstimulation. It should be the risk that we have here is multiple pregnancy, which carries a long-term risk to the baby and the mother. And many of our gynecologists always worry about hyperstimulation, especially in gonadotropin-induced cycles. And hyperstimulation is we call it as hyperstimulation when there are more than 10 or 15 follicles in each of the ovaries, not when there are 3 or 4 follicles in each ovary. So we should cancel the cycles when there are more than 3 follicles in both the ovaries together. But the risk is when you have 3 follicles, it is multiple pregnancy, then more than hyperstimulation. Next slide.
I think here also what is important is that you do the sonography monitoring yourself, and this cannot be done in coordination between a gynac and somebody else doing the ultrasound. So close monitoring and titration of the dose here would be important for such a patient.
And cancellation is very important. And definitely gonadotropins have higher success rates when you compare with oral ovulation. But the main risk associated with these gonadotropins is a multiple pregnancy. That is what the guidelines also will suggest. And guidelines are also suggesting to go for gonadotropins on their own without adding clomiphene or other ovulation agents to improve the clinical pregnancy and live birth rate. They have moderate, low evidence for this, evidence-based guideline. And consider cycle cancellation and abstinence when there are more than 2 follicles, more than 14 millimeters in size. And there is no difference in clinical efficacy of available gonadotropin preparations. So whether you use FSH, recombinant FSH, urinary FSH, or urinary HMG, the success rates are the same. There is a lot of misconception that, you should use recombinant FSH only in PCOS patients. So the guideline doesn't support that. Next slide, please. So this is another thing. I don't know if we have time for all this. We are already reached 5 o'clock. What do you say?
Mr. Selvam, do we have time to continue?
Yes, doctor, maybe another 5-10 minutes. The audience is the same, they are intact.
Okay. So laparoscopic ovarian drilling, how many of you would you suggest your patients to go for laparoscopic, and who are the patients who you would take for laparoscopic ovarian drilling? So
IMH, ILH, yeah. People who are not affording. We are talking about in our country, people who cannot come for monitoring for gonadotropins, who are not affording, who are young patients, high AMH, high LH. These are the people who are going to, or who need, or for in whose case, anyways, laparoscopy is indicated.
Yeah.
To see the pelvis. You need a tubal evaluation. So in those patients, selective group makes sense.
Okay, Dr. Mahesh.
Yes. I feel the laparoscopic ovarian drilling as of now is almost not to be done, because we see more zeal with which people have done. There is a loss of ovarian reserve. There's a lot of, the ovary completely gets burnt off. So I don't recommend ovarian drilling or any kind of ovarian surgery, because there is a loss of AMH. Loss of studies have proved that AMH pre-surgery and post-surgery is going to fall. So I think because the benefit also is very temporary. So I don't think even if there is a patient is saying, we should go for it. The other gonadotropin, other more safer ways are much better, because this is going to cause a lot of adhesions, fall in AMH and other complications. So I'm not for ovarian drilling.
Anyone supporting laparoscopic? Dr. Krithika, Dr. Mona?
Yeah, I'm seconding Dr. Mahesh, because guideline says a good gonadotropin stimulation gives you an equivalent pregnancy rate as lab drilling. And remember, lab drilling again is not cheaper. It's again going to cost you lesser than your gonadotropin stimulation. So why don't we do a non-invasive method with a good stimulation dose? So I don't do drilling at all.
Okay, Dr. Mona? I think she's not.
No. Even
Dr.
I hardly, very rarely.
So all our IVF consultants are against to laparoscopic ovarian drilling.
Dr. Sandeep, I think, is for...
I have done it a lot in past. I have worked in a setup when people were not very affording. So in those patients, and it depends on who's doing the drilling. If I am the one who's doing the drilling and I am an IVF specialist, I am not going to be over enthusiastic and drill 20 holes in one ovary. I'm going to be very careful because I know the patient could turn back. So it depends on who's doing it.
The literature says...
And you're following protocol or you're not following protocol. That goes for all management across board. It could be gonadotrophins, it could be drilling, it could be anything. So you have to follow guidelines and follow protocol. I think you will be fine.
So young patient, less than 3 years of infertility, BMI less than 25, AMH less than 7 and LH more than 10. They are the candidates who would give good response. And definitely, as Dr. Sandeep has told, patients who can't afford any high cost treatments like gonadotropin ovulation induction and IVF, they might be the ideal candidates to go for laparoscopic ovarian drilling. And also how you drill is also very important. You have to correlate the amount of energy you give and the amount, the ovarian volume, then only you would be able to be successful. Otherwise, majority of the ovarian drillings, what is happening, we are going very lightly onto the ovaries and then the outcome is also poor. Yes, Dr. Krithika?
Yeah, I would just like to know Dr. Mathur's view about drilling, whether he does or not.
1 second, Selvam, can you give me access for the sharing, screen share?
I can stop sharing and you can share, Dr. Lakshmi.
Yeah. Let Dr. Sneha. Stop sharing.
I don't want to change the, I don't want to share, but I want to share the change the slides. Can I do that?
Yes, when I stop share, you can share.
No, you share, but I will change.
No, that will not be possible.
Okay.
If you share, you can change.
Okay, just leave it.
Yeah.
Should I go to the previous one?
Yeah, please. Yeah. Dr. Raj, please.
So I was going to say that we do it much less than we used to. We do it mainly for women who are having a laparoscopy for some other reason, hydrosalpinx investigation or something like that. In my hands, it has never been particularly successful on its own. But in some resistant cases where they don't want to have IVF, it makes them a bit more responsive to clomiphene. In the old days, clomiphene, nowadays maybe letrozole afterwards. So yeah, we don't, I maybe do literally in the single figures each year. Yeah, very few.
But do you
Thank you,
whom you have taken for laparoscopy?
Sorry, say again.
If your patient is a PCOS patient and you have to go through for a laparoscopy for some other reason, would you do it?
I will definitely discuss it because the risk from it is going to be relatively small. We don't do multiple holes. We use the old 40 watts, 4 holes, that kind of formula. So it's not going to cause much ovarian damage. There's a theoretical risk of subovarian adhesions, but I think that's mainly theoretical.
Yeah.
I've actually seen it.
And one point that I would like to make to all our viewers is that please don't do an advanced stage. Because we have seen so many, 35, 37, and they have been, they undergo drilling at that age. And then when they come to us, they are already like in an ovarian failure.
Majority of the times what happens is it's either done very less or too high dose of the energy given to the ovaries. Next slide, please. So we have to adjust the dose that we give to the ovaries according to the volume. Next slide.
You have to understand then when we say 3.5 is a cutoff for PCO, 3.5 to 7.7 is a very, very vulnerable for going for a premature ovarian insufficiency. So I think drilling should be out only now.
So the guidelines say that laparoscopic ovarian drilling should be taken as a second line therapy for women with PCOS who are clomiphene resistant or letrose resistant, or if we are doing laparoscopy for any other reason, we should offer them laparoscopic ovarian drilling also at the same time. Next slide. And while we are discussing, we have to tell them about the cause and the side effects, what we have already discussed. And the advantages or relative efficacy, single procedure, no monitoring is needed, cause and side effects have to be discussed. Potential long-term considerations like reduction in the ovarian reserve should be informed to the patient. Next slide.
So that brings us to IUI for women with PCOS. What do you have to say about HSG? For which patient would you do an HSG? So initial fertility management, when you're planning ovulation induction with letrozole, no other infertility factor, you would probably skip doing an HSG. But when would you go ahead and get it done before any other further fertility treatment? Dr. Mona?
Yes, so I would do it before an IUI, or if she has not responded for say 4-5 cycles of induction, like if it's a very primary patient, young patient, and no other risk on ultrasound other than PCOS, so we are not suspecting anything else. But if there are any risk factors involved, like any history of PIDs or say a suspected endometriosis along with that, so if some other suspicion is there, then I think I would prefer, or if it's a very long infertility and as doctor said that they're not willing for IVF next, in that case probably a laparoscopy would be.
What about gonadotropin ovulation induction? If she's going to spend on gonadotropins, would you prefer to do an HSG, confirm tubal patency, or at least give her the option that
yes, because not in all, maybe not in the first cycle or so, but then if she's not responding, I would give her an option, or I would let them choose if they want to consider going for an HSG first, and explain the consequence, because it's a very simple procedure, a day care procedure. And sometimes we, in such cases, we even do a sonosalpingography for them. Because when in low risk where we are not suspecting a tubal issue, even a basic sonosalpingography is good enough.
Okay, let me come to this case. 33-year-old trying to conceive since 4 years, cycle sometimes irregular, BMI 26, tried multiple cycles of OI, there is no male factor. Now you've planned an IUI cycle, you're giving gonadotropins for stimulation. On day 7, you see that there are more than 3 follicles around 13 to 14 mm in size. So how do you go ahead for such a patient? Dr. Krithika?
So usually when you find it's an alarm signal that you get more follicles, I would like to stop my stimulation, give her an option of cycle cancellation. So I would like to play safe in this case, then go ahead with the further stimulation.
So this, obviously, if you have 3 to 4 follicles maximum and not any more, cycle cancellation is the first option. If she still insists that she wants to go ahead with IUI.
If it is only 3 follicles, then I would give her a counseling about the risk of multiple pregnancy and then proceed accordingly.
What if there are many follicles, like 8 to 10? Some other gynec is stimulating, planning to send for IUI to you, and the patient has multiple large follicles.
Then definitely we'll have to give them an option of converting that cycle to IVF, and have to discuss the pros and cons with the patient, that we can reduce the risk of OHSS also by converting it to an IVF cycle.
Any specific points when planning to convert an IUI cycle to IVF? Dr. Mona, do you see a lot of these patients?
Not a lot, but maybe like 1 or 2 every year. But still, we ask the doctor, or if it's a stimulation being done outside, we ask them to continue with the gonadotropin. So we usually don't advise the coasting, and we ask them if the patient is willing, then only. And if we ask them to add an antagonist when the follicles are around 14 mm, 15 mm, not beyond that, because then there is a likelihood of ovulation occurring. So continuing both the gonadotropin ongoing as well as the antagonist, and then triggering with decapeptyl. So that is a GnRH analog trigger always, and then freezing all the embryos and subsequent transfer in the subsequent cycle.
So for our audience, basically, if you have planned gonadotropin stimulation for a patient of yours, she has not responded for a low dose and you have had to increase the dose in a subsequent cycle, you need to counsel the patient beforehand that she may need to cancel cycle if too many follicles grow, or maybe have the option of converting to IVF. So the gynac will have to do this in liaison with an IVF center. And the main step is coordinating with the IVF center on the correct day, continuing or increasing the dose of gonadotropin, adding antagonist, and planning trigger depending on the particular case scenario. This again is a patient who has 3 to 4 follicles which are growing. She's not ready to cancel the cycle. So in my practice, I see a lot of such patients referred directly for IUI, but with an agonist trigger. So she has only 3-4 follicles, not any more. So when the number of follicles is not too large, it is not OHSS that we are worried about. It is multiple pregnancy that we are worried about. So this is just the point I wanted to drive in for the audience. Dr. Lakshmi, would you like to take up?
Yeah, I think Dr. Mathur has just messaged that he has to leave. I think if you can give our audience your take-home messages, crisp few points on PCOS.
With pleasure. Although I think you have all done a fantastic job. This has been such a good discussion. I personally feel I've learned a lot. I'm really grateful for this. It's been fantastic. In the middle of my clinic to get this education has been fantastic. If I have a take-home message, I will go back to my favorite, not my favorite, my one topic, which is OHSS. Please be constantly careful of the risk of OHSS. Please try and use freeze-all in a really sensible and educated way. If that means working with your laboratory first so that they get the freezing program right, and then you're able to offer a freeze-all and prevent OHSS in the high responders, I think that would be amazing. That's my final message. Thank you all very much.
Thank you, Dr. Mathur.
Dr. Raj.
Thank you very much, Dr. Raj. Thank you very much.
Dr. Raj.
Yes.
Yeah, just one question, small, because you are in the hyperstimulation, you are the master in that. This is of late we have been actually, even in spite of giving GNH agonist to the patient trigger, we are often seeing the patients who is going to moderate hyperstimulation.
Yeah.
So we just can't completely negate those patients. What would be your recommendation in those patients? Do you think something else we can do in these patients? Like, can
we are now giving them cabergoline from the day of trigger as well. So 0.5 milligram day of trigger for 8 days. I have also seen moderate hyperstimulation after agonist trigger.
Yeah.
It doesn't
hardly follicles 25, egg retrieval maybe 18, and still she goes. Few patients still has that moderate hyperstimulation. In spite of all things, we have given her cabergoline, everything. So I think there is some set of patients who is just not being, OHSS free at all.
It's not possible to eliminate it. I think this concept of OHSS free clinic is optimistic. I don't think in practice we will ever get 100% elimination, but we have to do what we can.
So you would give cabergoline from the day of trigger, Dr. Mathur. Anything else?
Well, there is a debate about whether we should continue the antagonist for
beyond pickup.
It adds to the cost quite a bit because cabergoline is cheap, but the antagonist is expensive and it's not strongly evidence-based. So we don't do it for everybody.
All right. And what about letrozole? Did you try?
No, we have no experience of using it for prevention.
We give actually to reduce the E2 level. But
Yeah.
still
And any thoughts, either Dr. Bharati or Dr. Raj Mathur, on hydroxyethyl starch?
Starch we give.
There's evidence that it helps, but I'm slightly cautious because we used to all say albumin, which works in the same way as hydroxyethyl starch, and we know now that albumin doesn't work. So I'm worried that HES will go down the same. There is that graph of an idea that takes off, suddenly becomes very popular, and then goes down after that. I think HES is on that phase, and then it will go down after that.
And Dr. Raj, if the patient's PCV is very high, like 40, 45 or 47, Do you add a low molecular weight heparin? Does it really help?
We do, just
Or
because
do you
we're scared of the risk of thrombosis. So we do add, and we also individualize it, because if they have other risk factors, then we continue the, because the thing about the OHSS thrombosis is that it can occur 5-6 months after the OHSS, particularly if they conceive. So you might think, oh, she's okay now. She's okay, except that the thrombosis will occur a few months later. That's the
And one more last question, that in case the patient has a moderate, severe, kind of a hyperstimulation, when should be the right time for her FET? Like, because you know that this is all we have given her.
Yeah.
Is there any timeline? Is there any studies that this could be a safe zone, 1 month, 2 months?
So I don't think there are any studies, but you have to be able to monitor the FET. So you have to be able to know if you're doing are you going to do natural cycle, then you've got to be able to find a corpus luteum or a follicle developing and so on. And if you're doing a natural cycle, then with hyperstimulated ovaries in the previous cycle, it may be very difficult to monitor her. So I think other than that, there is no evidence for delaying or going straight away.
Thank you.
Thank you. Really interesting discussion.
Thank you so much for joining us. You added a lot.
Thank you, doctor. Thanks a lot.
Thank you, Dr. Mathur. I think we have run out of time. Dr. Lakshmi, do you want to do the pregnancy outcome and the flow chart?
So even in IVF patients, we will be continuing with the same protocol with low dose protocol. And then we'll gonadotropin wise, whatever gonadotropin we use, it doesn't matter whether HMG or recombinant FSH, even the guidelines support the same thing. So we are only skipping off all these slides because of lack of time.
Yes, should we? I mean, if we can go ahead, I'll go back on them. Mr. Selvam?
I mean, audience are there.
No, doctor. No, doctor. Let's conclude. Yeah.
Okay.
I think there are a couple of questions. If Dr. Sneha, can you able to give them to the panelist?
So
Yes.
this flow chart that
Q&A.
guidelines have given us. So first, identification of the problem is very important. Not every patient who walks in with irregular cycles should be diagnosed as PCOS, though PCOS is the most common anovulatory disorder. So first, identify the problem, diagnose according to the Rotterdam criteria. We do all the investigations, exclude other causes of anovulatory infertility. Then optimize the preconception health and lifestyle. So again, optimization depends on the scenario, how long they have been trying and what is the age of the patient. And once this is achieved, then we have to start the first line of management, letrozole. The dose is 2.5. We can go up to 5 milligrams. And though some of our panelists did not agree with the extended dose regime, but it definitely helps. In majority of our patients, they ovulate with 5 milligrams 10 per 10 days. Or sometimes if they are not responding to 5 milligrams for 10 days, we can even go up to 7.5 milligrams for 7 to 10 days. We have seen quite a good response. And any of these patients who are resistant to ovulation agents, we can add metformin, insulin sensitizing agents, and that also will help. And if ovulation is detected, we can continue for repeated cycles. The number of cycles can be around 6 to 8 cycles. And if it did not, the patient did not conceive after 6 to 8 cycles, maybe we can go up the ladder either by adding gonadotropins on its own or with clomiphene citrate and metformin. And once ovulation is detected with gonadotropins and after a few cycles and repeated cycles and still the patient is not conceived, then the third line option is IVF. And in between, at that stage of gonadotropins, you can discuss about laparoscopic ovarian surgery also, along with gonadotropins as a second line of management. And having said all this, before we start all this, we should subject our patient's husband for a semen analysis. And we also should make sure that the tubes are patent at least after 3 cycles of ovulation induction. Dr. Patil, you want to add anything to this? Not audible.
Doctor, you're on a mute.
I think Lakshmi, you have done the wonderful job. You and Sneha has done a wonderful job. These are the guidelines actually, and they are overall is been seen. But I don't agree to this first line and a second line and a third line. I'm sorry to say this all. This is all actually is going to change over a period of time. But by then, actually, for overall people should follow these, but they should not waste the time of the patient for a long time, because one doctor giving clomiphene citrate or a letrozole, the second doctor again his first or her first line is again a letrozole, again a clomiphene. They have to agree that that doctor has been done that, and we have to agree whatever has been happened in that cycle. So I think we should quickly. Time to pregnancy is very, very important. Time to pregnancy has to be kept in everybody's mind, because her age is limited. She is soon going to be 35 years. So please remember this all. Otherwise, you have done a wonderful job. I think you, Sneha, has done wonderfully, the whole PPT presentation. And I think Dr. Raj has added value to it. Thank you very much.
Thank you, ma'am. Thank you so much. Definitely, we have to take into consideration what the patient has gone through already. It shouldn't be like the patient came to you, so you'll start all over from the beginning. We have to take the patient's history, how she responded to the previous stimulation, and depending on that, you have to start your treatment from there. Definitely agreed.
I just want to add, one patient came recently to me, and she's done 6 multiple ovulation induction and TI cycles, then 3 IUI cycles. And the patient comes to me and she says, doctor, you will do something different. I said, I can't do something different here. It has been already done. Now I have to step up. If I don't step up, then I will not give you pregnancy. So I'm here to step up, not to repeat the same thing what has been done up till now. And we should not take pride into that. And the patient, नहीं डॉक्टर आप बहुत अच्छा कर सकते हो, आप इसीलिए आपके पास आए हैं, आप बहुत ही एक्सपीरियंस हो. वो एक्सपीरियंस अगले चीज के लिए है, वही रिपीट करने के लिए नहीं है एक्सपीरियंस. If that take home message go to the everybody, I think we will be doing justifying the treatment or a management to the patients, especially IVF consultants. All. Thank you so much.
Thank you, Dr. Bharati.
Dr. Krithika, you want to add anything, one final point, each of our panelists, before we conclude?
Yeah, I feel a good stimulation and a step-up protocol will definitely make your resistant PCOS also ovulate. Don't give up. Slow and steady wins the race.
Perfect. Dr. Sandeep?
What I would say, I agree with Dr. Bharati, you have to individualize your patients, what patients need what, and then accordingly you decide as to it. One size fits all does not work out, is what I would say.
Especially in PCOS, yeah.
Yes.
Dr. Mona, are you still there? Dr.
Mahesh?
I think they have left.
Yes.
Yeah.
So,
All right.
Thank you all for being part of this wonderful panel. And it's been very good to be taking suggestions and interpretations from you all. And you added a lot of value to our panel discussion. Sneha, for organizing all this.
Thank you.
Access.
Thank you to our
Thank you
panelists.
so
Thank you, Dr. Lakshmi. Thank you, Mr. Selvam, Disha. Thank you. Thanks, Sonia ma'am,
Yeah.
Dr. Rohit.
Thanks a lot, doctor. Thanks.
Thank you.
Thank you, everyone.
Thanks a lot.
Thank you so much.
Thank you, Mr. Selvam. Thank you, Lakshmi and Sneha, for doing a wonderful job.
Thank you, everybody.